We just re-intubated a patient we just extubated. Oh, that's a technical fact. Oh, hey guys, how's it going? Well, you know why you're here, guys. You can see it. It is weaning from mechanical ventilation. Yes, and you know why you're here. It's not basketball, it's not technical fouls. It is all things respiratory therapy. My name is Mr. Cates and welcome back. All right, so let's get right into it. Weaning, or also known, liberating from mechanical ventilation. See it two different ways. Weaning or liberating, right? What is that? It's the gradual reduction or taking away from, right? So if a patient's on mechanical vent, we're getting them off of mechanical vent. We are trying to get them off, right? We are trying to extubate them or what may be, right? So weaning from mechanical ventilation, that is what weaning is. We're getting them off the ventilator, all right? So over here, we have some criteria. You gotta have some criteria. You gotta know your basis for weaning. If you should wean, or when it's successful weaning, when you can extubate, right? So let's look at some of these parameters. Right here, number one, we got the RSBI. This is rapid shallow breathing index, guys. This is a formula that is respiratory rate divided by tidal volume. Very easy. And this number needs to be less than 105. And here's a little secret. It does say best over there. And it is. There are so many studies done on RSBI, and that is your best predictor. If you are less than 105, you have the highest success rate of weaning or extubating with an RSBI lower than 105. All right? So then we look at number 2 on the list. It's MIP, or also known as NIF. And this MIP is maximum inspiratory pressure. Also interchangeable, same thing as NIF, which is negative inspiratory force. And when you see this or get this, you need to know that it needs to be negative 20 centimeters of water or more, right? And why negative 20? Negative 20 is the minimum that you can that the patient needs to generate in negative force to be able to produce a cough. So you're not going to extubate this patient if they're unable to clear their airway. You have to secure the airway. Negative 20 is that number. That's why we look for negative 20 or more, right? So when we say more, negative 20, negative 30, typically the normal is around negative 50 to negative 100, all right? So we're looking at a minimum of negative 20, and that's the minimum you need for your cough, okay? The next one is vital capacity. And on vital capacity, now this one is a little bit skewed. It's probably out of all these, probably the least one. And the only reason for that is just because it takes a lot of patient cooperation. So the patient has to be cooperating in this, and in a time of weaning, and when a lot of things happening, that's a difficult thing to have. So that's why it's a little off, but we still have it. Vital capacity, usually for your neuromusculars, right? Your Guillain, myasthenia, right? So you're looking at what? Greater than, right? More than 10 to 15 milliliters per kilogram, which is your ideal body weight, right? 10 to 15 milliliters per kilogram. You got to be over that, right? The next is your FiO2 and your respiratory rate. Your FiO2 here, it has to be less than 50%, guys. Okay, you'll see it in some texts, it's 50 to 40%. Stick with the 50. Got to be under 50%. If you're requiring higher than 50%, you're not ready to come off the ventilator just yet. All right, next one is respiratory rate, or frequency breaths, right? And this one, you got to be under 35. If the patient is still over 35 and oh man, their respiratory rate is off the charts, right? That's really high. What's our normal? 12 to 20, right? So you should be around there, and you might be a little bit higher. And I was going to say hyperventilation. It's a common thing when you're about to extubate a patient, right? You're about to go, they're breathing a little bit fast, but that's normal, right? That could happen. But if it's greater than 35, we're not ready, okay? So things to look forward to, or not look forward to, but look for, are drugs that suppress ventilation. So you can get all these things right here, look great, but then you look over and your patient is on one of these drugs, and I wrote them. It's a narcotic, neuromuscular blocking agents, anesthetics, right? So when you look and you see that the patient's on there, you got to discontinue those, right? You got to stop those when you're doing these weanings. And the reason why, it suppresses ventilation. It suppresses your respiratory system, right? So you can do all the stuff that you want, and if you're not breathing, you're suppressed, weaning's not going to happen. So we're not going to do that, right? All right, so one thing I want to get into over here real quick is, well, how do you get these, right? RSBI, you know, respiratory rate and tidal volume, you can get that off the ventilator or whatnot, right? But really, bedside spirometer is what you need, and that's a respirometer. Bedside PFT, and that's a respirometer. It'll get you your RSBI, because what it does is it gets you respiratory rate and tidal volume. So again, a respirometer is a bedside spirometry tool, or bedside PFT tool, not spirometry, but bedside PFT tool that will give you your respiratory rate, your tidal volume, which then gives you what? Your RSBI, okay? Rapid Charlotte Breathing Index. The MIP, the MIP or NIF, right? You're going to get this with a pressure manometer, okay, guys? So RSBI, you can get that getting off the vent with your things there. You can get that with a bedside PFT, which is a respirometer. And then the MIP and NIF, you get that with the pressure manometer. And that's where you get those, okay? All right, so let's get right into some things about modes, ventilator modes, weaning modes, okay? And one thing that I want to really get into is you got to focus. If it's weaning, it has to deal with some spontaneous breaths. That's the first thing. Spontaneous breathing. Patient breaths. They're breathing on their own. If you're going to wean somebody, you don't want to fully ventilate or fully control tidal volumes, respiratory, right? You want to allow the patient to do some spontaneous breaths, some breaths on their own, okay? So when we do that, this is, okay, when I write this down, this is pretty much the order, and the MBRC likes to slow. Now, there are some incidents that you can go from assist control, right, and go straight to extubation, or straight to, and you don't have to do these weanings, go. And those are going to be normal, or people that are drug overdose, because a drug overdose, there's nothing wrong with their lungs. It's the drug, just like we said over here, that suppressed their respiratory system, right? So we can go straight to extubation if we know it's a drug overdose, or this is a normal patient with no lung condition, right? Or nothing happening, right? So those are the times that you just go straight to extubation, okay? No weaning, all right? But in the MBRC and the way they look at it, they like to slow it down, right? So if you, let's just say you're on assist control, okay? The next for weaning would be SIMV. And if you don't know what I'm writing here, you don't know these modes, these are going to be in another video. You're going to look at these modes and figure these out. But this one is synchronized intermittent mechanical ventilation. So this one is synchronized. It is what? It's allowing them to what? Spontaneously breathe. So in assist control, right, sum it up, that is delivered if you're giving 12 breaths and 500, it's giving 12 breaths at 500, no change. Now the patient can trigger and cause their own breath, but it will still be at a tidal volume of 500. But SIMV, same principle, 12 and 500, but now when the patient triggers and takes their own breath, they're allowed to get their own tidal volume. You see what I'm saying? So we'll go through those, right? And then the next one would be CPAP, right? Or T-bar, okay? T-bar, or T-trials, they call them, T-trials, okay? And really, what you're doing is you're doing spontaneous breathing trials, SBT, right? Spontaneous breathing trials, that's what you're doing here, okay? So, this is the order, guys, okay? They like to take it slow. So assist control, bring them to SIMV, bring those rates and the pressure support, right? Minimum, okay? Then you get to CPAP, Then once you get to CPAP, about a CPAP of 5 and about 5 to 8 on the pressure support, plus 5 to pressure support about 5 to 8, and less than 50%, right? And then there's another thing, right? That's the CPAP, and I'm gonna write it here. You're usually gonna start with plus 5, and then your pressure support ventilation. This is gonna start around 5 to 8, okay? And that's your pressure support on CPAP, okay? But there's another way where you can take the patient off and you can put them on a trial, right? On a T-bar or these T trials, right? But it actually, the studies show that takes a little bit longer time to do when you fully remove the patient from any type of assistance and you have them do it on their own with the SBT trial. So, well, the studies are showing that it actually takes a little bit longer to do, but it is another method, right? CPAP is the method, but you could choose, right, an off, without support or anything, spontaneous breathing trial, right? Now, one thing with these spontaneous breathing trials, right? Now, they can go up to 30 minutes to 2 hours, okay? 30 minutes to 2 hours, okay? And they can be daily if they pass. You can extend it a little bit longer. Start at 30 minutes, go to 1 hour, keep going up. You see what I'm saying? But if they fail, if respiratory goes up, diaphoresis, right? Any cardiac arrhythmias, patient doesn't look well, rates are going up, they're not meeting these criteria, right? You'll see it, heart rate, all these things, right? These signs that they are not are successful, or they're not, gonna make it, right? So what are you gonna do? You're gonna put them back on mechanical ventilation. You put them back on assist control, right? You give them full support. They already had their workout. Now you put them back on full support, all right? And you leave them for a day. You don't go back later that day. You wait another 24 hours, guys. That's the caveat. If they fail the breathing trial, don't do it later that day. You got to wait 24 hours to do it again. And how long do these trials go for? 3 hours, 30 minutes to 2 hours, all right? So you want to kind of follow this pattern, right? Assist control, right? SIMV, and then CPAP, okay? And then also you can change these out with a spontaneous breathing trial or CPAP. And I told you the CPAP gives a lot of positive end pressure, right? That's the PEEP, right? And then you also get that pressure support to overcome that resistance. So, you're helping out a little bit, but you're also not setting any tidal volumes with the CPAP, right? You set no tidal volumes. They generate their own rate and tidal volumes, okay? So anytime they're on CPAP or off the vent and they fail this, if they go apneic, right? They stop breathing, cessation of breathing, you would always revert back to full support. That's always the revert. Don't kind of go back down the tree. No, you go back to full support, okay? One other thing too is you never want to, you build up, like, let's just go small steps. You go from nasal cannula to BiPAP to mechanical ventilation. It's not a ladder effect, guys. It's not mechanical ventilation to BiPAP to nasal cannula. No, it's off the ventilator with minimal, no mechanical, not non-invasive, not, obviously you're taking them off the ventilator, but the minimal, so maybe a nasal cannula, like an oxygen device, but you're not gonna go, I'm taking them off to put them on BiPAP. That's not what you do. So I want to make that clear. You take them off to put them on an oxygen device, but not for any support of BiPAP, okay, or CPAPs or anything like that, okay? All right, and so just to be clear here, guys, this is just a slow method. Remember, you could be on AC and go straight to extubation, pass all this up if it's normal or drug overdose. But if we're seeing something and they're long, and remember, the longer they are on the ventilator, COPD, right? Longer they are on the ventilator, it'll be longer to take or to wean them off, right? It takes a little bit longer. So start your breathing trials, start your CPAP trials, right? Start getting them off, right? So let's just recap right here, right? So we know Weaning, liberating from mechanical ventilation. Weaning, liberating means the same thing. Taking them off of mechanical ventilation. We unpack the criteria. RSBI, #1 predictor, right? The highest studies. You got to be what? Less than 105. Good to go. Easy to get. Respiratory rate divided by tidal volume. How do you get it? You get it with a what? Bedside PFT, a respirometer, right? That gives you your respiratory rate and your tidal volume. That's what gets you. All right, then you got your MIP or your NIF, right? And what does that need to be? It needs to be what? -20, right? Minimum for the cough, okay? And you're going to get that with a manometer, pressure manometer. Okay, then you got your vital capacity, remember? And then your FiO2 has to be less than 50%, respiratory rate less than 35 breaths per minute. All right, guys, we are going to send out another video, and we'll have a lot on mechanical vent, and we'll have, you know, you'll see the video out there with the modes, all sorts of stuff. But you let us know what you want to see. Subscribe